Good morning and good afternoon, everyone. I want to welcome you to the first Topics in Spinal Cord Injury Rehabilitation webinar. I am Monica Perez, Editor-in-Chief of TSCIR. We are excited to launch this new webinar series in collaboration with the American Spinal Injury Association. The goal of these webinars is to highlight impactful research in the spinal cord injury community that has been published in TSCIR. I would like to thank Dr. Mark Nash, President of Asia, the Asia board members for their support of this initiative. Many thanks as well to Patty Duncan and Caroline Moffat for really helping us to make this idea a reality. TSCIR is the leading interdisciplinary journal serving the global spinal cord injury community. Our scope spans from foundational science, clinical practice, to systems level innovation. We encourage you to submit your work to TSCIR and join us in our effort to continue to advance the field of spinal cord injury. Today, we will highlight two important papers that discuss the role of the international standards for neurological classification of spinal cord injury, or the INSCI exam. For more than 35 years, the INSCI exam has served as the preferred methodology for classifying neurological impairment. Our panel includes 3 experts in the field with extensive experience in using, improving, and modifying the INSCI exam. We will have 2 presentations, so please post your questions in the Q&A, and we will discuss and open the discussion session after the presentations. So I would like to begin by inviting Dr. Rüdiger Rupp. He's a professor at the Spinal Cord Injury Center at Heidelberg University Hospital in Germany to provide a short overview of the relevance and significance of the papers that we will be discussing. And these papers were part of a TSCIR special issue. So welcome, Rudy.
Thank you very much, Monica. And I'm really excited that this webinar takes place. So over a year ago, actually, when we put out the call for the special issue of international standards, I was not really sure whether we will make it then to fill a special issue on this topic. But a year later, I'm extremely happy that this special issue actually contains 11 excellent publications. 8 of them then are focused then on the INSCI exam, and 7 are for members of the Asia's International Standards Committee, for which I serve as the current committee chair, and Stephen Bernstein is a member of it. Why did we submit our material to topics? Might also be interesting, and also for the audience. As hopefully most of you know, topics Asia members have a complementary access actually then to topics, and we thought that Asia members are really then the primary target audience then for our publications. When Monica asked me to select 2 publications then from this special issue, I immediately chose the first manuscript on the topic of the development and evaluation of an abbreviated INSCI exam. And why is this of relevance? Because we receive constantly actually then feedback from the SCI community because there is a high need actually then for an abbreviated exam, still a standardized exam based on the procedures that are relevant then for INSCI. What makes this publication, I think, also unique is that it is not only consensus-based, but really evidence-based, because we performed an analysis actually then of a large data set from a registry, which I think is also something unique. The second manuscript, which is presented then by Ron Reeves, which is in fact actually then a series of 2 manuscripts, presents cases where the changes that we introduced with the 2019 revision then are illustrated, and there is a focus then actually on these changes. And there is also a high need, and I think then also for such kind of training cases, because it takes really time, and it helps really then to adopt the changes of standards actually then in the field more rapidly. And that was the reason why we believe that this series of manuscripts should be presented and the topic of our webinar today.
Thank you, Rudy. So I'm going to invite Dr. Stephen Burns, who is a professor in the Department of Rehabilitation Medicine at the University of Washington and the VA healthcare system in Seattle, Washington, to open the first presentation.
Great, thank you very much. Are my slides projecting correctly?
Yes.
Yes.
Okay, great. So yeah, it's really a privilege to present on this topic. to what I know is an experienced audience that have opinions about the full exam, and every time that this has been presented since we've developed it, received some useful feedback toward it. So I would love to hear from folks the questions during this or following up directly through the committee. So I'm going to be doing a very brief summary of this manuscript that was published in August in Topics. So the rationale, so everyone that's done the full exam understands why it would be nice to have a shorter option. There are 134 things in the full exam. You had no previous options before the E-INSCI to do anything shorter. It's probably the longest clinical exam within medicine. So we needed a standardized shortened option, and we learned from development of the electronic algorithms that a lot of the exam doesn't really contribute to the classification. So there was some obvious stuff that could be shortened. We did put out version 1 in 2020 after presenting it to the field for a couple of years. It was not strongly supported by the accuracy analyses that are in the recent publication, and the feedback we got from the field was people loved having a shorter option. Everyone felt like they were doing it the right way, but in truth, the instructions were very vague, and other than the videos that had been posted online, it was hard to tell from the written instructions what the steps would be. And when we went to determine what the accuracy of the classifications was and how many steps with version 1, it was essentially impossible because the instructions were not very precise. We were able to evaluate one of the shortcut options that I'll mention here. So in the attempts to validate version 1, which was going to sort of go nowhere, we ended up creating the version 2, which was just published. So the instructions are very precise, step by step, and that's actually what is detailed in the manuscript, an algorithm of first you test this and then you test this. And the two classifications that this determines are NLI and AIS, similar to version 1, and we determined what the accuracy of the classifications was and the number of steps on average required. And then we also looked at the previous option for substituting S1 sensory and motor in place of the anorectal exam findings, which was an option in version 1, but you'll see is no longer an option in version 2. So the analysis is published in the manuscript. And it's really hard to understand this without understanding the step-by-step part first. So before I show what the accuracy is, I'm going to just review this. This is one of the 4 case example videos that's posted on the Asia website that go through the different options for, especially for how the NLI is determined. Some variation there. So the first step is to do full motor testing. So the 10 key muscles bilaterally, you do that first. And then based on what you see with that, then you're doing sensory testing guided by the motor findings and the minimum amount needed to identify the NLI. And then the remaining part is determining the AIS, so a potentially shortened approach to how much S4-5 and digital rectal exam testing is needed. So I will demonstrate. This is case 1 on the Asia website. So starting with hidden worksheet, we'll reveal this part by part. So the first step is to test motor function. So I'm revealing it all there. Then we look at this and we determine something we are terming a presumed motor level. So if we only had the motor to look at, what do we think the motor level might be? And we have a 5 here, we have a 2. So C5 would be the presumed motor level, and similar on the left side. We can also note there's a whole bunch of motor sparing 3s, 4s, and 5s in the lower limb, so we can conclude this is probably going to be some sort of motor incomplete injury from that. But let's move to determination of the NLI. So now we have to look at sensory. So in this example, I'll just show it starting with light touch on the right side. It could be started on either side. And we only have to test down through that presumed motor level. If it turns out that the sensory level was something causal to this, that's not going to be determining the NLI. It's only going to determine the NLI if it happens to be abnormal at C5 or something rostral to that. So the testing would start at C2 with our first light touch testing. We would work our way down until we hit a 1 or a 0, or we reach that level that is the presumed motor level. And it's a 2, so we don't have to test sensory any further down in that column. Now we move to pinprick on the right side. We'll test it starting at C5, and that's intact. For the remaining columns here, we want to see 2 consecutive dermatomes that are intact for some certainty that that probably is defining a level at which everything rostral to that is going to be assumed to be normal. So then we would move to the contralateral side, starting our testing with light touch at the level corresponding to what we had tested on the previous side and determined to be normal. So it would be C5, light touch. We check C5, we check C4. So there we've got our 2 consecutive normal dermatomes. And then we would just test our remaining pinprick levels. So that's how much we would have to examine to determine the NLI. I'll show there that the NLI is C5. In this case, we're assuming everything that was untested is normal. Next, we would determine the AIS. So we start with S45 testing. We show a 1 for right S45 light touch, and that's all we have to do for S45. At this point, we know that this is an incomplete injury just based on that, so we don't really care about the rest of the S45 findings for classification. So normally we would be doing the anorectal exam, but in this case it isn't needed. Why is it not needed? Well, we already know this is an incomplete injury, sensory incomplete because of the S45. And with motor level at C5, we have motor preserved more than 3 levels below the motor level. There's all this sparing down here. So it's an incomplete, motor incomplete injury. We don't care if VAC was absent, if DAP is absent, it's not going to affect things at all. So we can completely ignore that. We know this is motor incomplete. We would count up our muscles and decide that this is AISD. So this is an example where the anorectal exam would not have to be performed. So that's what the sequence of testing looks like. This is just circling and showing what the full exam, the part we didn't test, is showing. This required 23% of the full exam, and we didn't have to do the anorectal exam. And this is how we would fill it out on the worksheet. We just show what we tested. We don't fill in what we think was normal rostral to what was tested. Okay, so classification accuracy. So doing things that step by step with some detailed instructions, where the best place to look for the instructions is what's posted on the Asia website, or it corresponds to what's in that manuscript. So we developed the step-by-step using 120 full exams from the EMSCI database. And we revised it because it wasn't performing as well as we wanted, and then retested on the poorly performing cases, and then tested another 100 cases. What we come up with, this process is 98% accurate for determining the NLI, and in the 100 cases we tested, it was 100% accurate for the AIS. On average, it was 42 exam steps, which is 31% of the full exam. And as in that example, we could omit the anorectal exam. And for most AISCs and essentially all AISDs, we can omit it. So next, I want to review the previously suggested option for substituting S1 sensory and motor in place of S45. We used a slightly different set of cases here. We used cases this time from the Rick Hansen SCI registry, over 7,000 cases, median 10 days post-injury, full exams, and by the previously specified substitution of S1 sensory and motor in place of the anorectal exam findings. The accuracy was not as high as we would have liked. So the overall accuracy was a little under 90%, 89.5%. It performs especially poorly for true AISV classifications. It's what's shown in the, not sure if my pointer's showing, but in the column on the left, the second row down. So it's only 55% accurate for identifying true AISBs. And since AISBs have such a variable and sometimes favorable prognosis for recovery, misclassifying those patients as AISA early on would be a big mistake. So in the end, we decided that this S1 substitution option should not continue into version 2. So some patients will require the anorectal exam, and all patients require at least a little bit of S4-5 testing, as shown in that example. The other part that did not perform as well as we hoped, previously we had suggested that S1 substitution could be used if the neurologic level of injury was T10 or rostral. And yes, there is a higher error rate with NLIs around T12 and L1, but as we go caudal to that, the error rate isn't all that high, and you can see an error rate that's above 10% at some common cervical levels. So that supported that we can't selectively apply that shortcut rule. So just that's no longer being recommended as an option. This is just a list of some of the resources that are out there. So look to the Asia website for the detailed testing instructions that are based on what is specified in the algorithm, which is in the manuscript. Instructions how to record the information, suggested uses. There's a table suggesting times when Folinsky versus Iinsky could be used, which is definitely an open topic for discussion. 3 additional case examples other than the one that I just showed. We are planning to have a training workshop at the 2026 Asia conference, and developing a plan to develop in-step style training resources. And at some point, the online classification calculators should be able to come up with correct classifications based on Iinsky, but at the moment, they're not programmed to do that. So I think that's my last content slide. So just to acknowledge everyone who participated with the manuscript.
Okay, so thank you very much, Stephen, for your presentation. We're going to leave the questions for the end. Please remember to post your questions in the Q&A, and we will start the discussion session after the second presentation. So it is my pleasure to introduce our second speaker, is Dr. Ronald Reeves. He is a professor in the Department of Rehabilitation Medicine at the Mayo Clinic in Rochester, Minnesota. So welcome, Ron.
Thanks so much, Monica, and to the entire Standards Committee. It's really an honor to be here. Hopefully, you guys see a slide that says Snyder, Kirschblum, and Rupp at all times 2?
Yes, correct.
Okay, so really, it's my pleasure today to just overview 2 important papers that appeared in the same issue, both authored by Dr. Snyder and the Standards Committee, and really both important contributions to the literature that add considerable material to help us understand some of the difficult classification challenges. And definitely want to thank you for your leadership of topics, Dr. Perez and Dr. Rupp, and the entire Standards Committee for their hard work in helping us do the best job possible with challenging cases and understanding and optimizing the standards. And so I'm very grateful to have the opportunity to share some thoughts. I also want to acknowledge Dr. Snyder's hard work over the last several years. And so this was a paper that she published with a couple of us back in 23.
Ron, sorry for that, but maybe so we don't see the presenter's view, but you're still the first slide. I guess you're already at slide 3. Maybe you should share the screen where you have the presenter's view.
I thought I was on the presenter's view.
Yeah, okay, then
Yeah, no, not
maybe
yet.
then just click below then for the full screen could help. I don't know. So
yeah.
But I guess you are already talking about slide number 3.
Oh, I shared the wrong screen.
As I said.
All right.
Yes, that looks great. Ron, that looks great.
Yeah. Thank you.
Now let's see here. Okay. So thank you for orienting me, Rüdiger. I appreciate that very much. My technical competence fails me regularly. And so hopefully you're seeing a slide now that has 2 manuscript titles on it.
Perfect.
And as always, Rüdiger's keeping me out of trouble, and I'm trying to get him into trouble. And so And again, I appreciate Dr. Perez putting up with my incompetence at these things. So now let's see if I can get my slides to advance. All right, did it advance for you guys?
Yes.
Okay, so this is a paper that Dr. Snyder and a few other of us collaborated on back in 2023, shortly after the 2019 revisions began to be disseminated. And what was noted during that study is that there are particular areas of the classification system that are challenging. And this is not a new observation. So Rüdiger and his colleagues have published this previously as well. And these challenges with determining AS grade and the ZPP have been understood for many, many years, going back to really the forefathers of the field who have helped to design the INSCI initially. In the two papers that are published that contain a series of cases, one of them I will refer to affectionately as a reinforcing concepts paper that really covers several key things. And so classification of the zones of partial preservations and incomplete injuries, the role of non-key muscle functions in classification, and then the challenging areas of managing non-testable and not determinable issues. And then also in the second paper, they respond to questions from the field that have been presented. And very nicely in both of these papers present a series of cases that can be examined in detail and described in detail. Additionally, there's a set of cases on the Asia Learning Center, 26 in total. Some of those cases are presented in these two papers, but there are additional ones there. On the Asia Learning Center, there's a version of the cases that do not contain the descriptions. And so cases only number 6. And then there's the full description of the details of the cases. And this is really a tremendous resource for the field. And I really appreciate the hard work of the Standards Committee in terms of disseminating these so we can all learn from them. So this is just one of the examples. And so this is an example which highlights the role of the ZPP as it relates to the presence or absence of sacral sensory or sacral motor sparing. And so in this particular case, there was volitional anal motor function present, but no perianal sensory function or deep anal sensation. And so it highlights the not applicable nature of the ZPP when there's voluntary anal contraction, but the relevance of the ZPP for the sensory examination. Now, in this case, it highlights how one would use the classification system and the not testable in the case of an amputation quite far above and distant and separate from the neurologic level of injury, and highlights the important utilization of this asterisk, but also the recognition that these sensory dermatomes and myotomes would be considered normal for the purposes of classification. Now, the next case that's presented is one that can be more challenging, where again, it's an amputation, but it's close to the zone of injury. In this case, immediately below it. And so we couldn't assume that these dermatomes and myotomes were normal for the purposes of the exam. And that's noted that they're considered not normal for the classification system here. Because the neurologic level of injury was C4, you didn't need to carry the asterisk down into the classification details because the area affected by the amputation wouldn't ultimately have affected the classification. But these two cases highlight how to use the NT designation both at the zone of and below. And so I really appreciate their addition because this is a common area of confusion for the field. Now, this particular case is really a beautiful case highlighting the importance of non-key muscle function as it relates to the determination of an ASB versus C or D. And it also brings out the importance of the motor sparing more than 3 levels below the motor level on the relevant side of the body. And these concepts and details are particularly challenging for the field, and the manuscript does a really nice job of describing why this would be classified as an L1D with the non-key muscle sparing of adduction of the large toe. And so I again appreciate the standards committee for bringing through really a beautiful example of these challenging ideas, and encourage everyone to go to the original manuscript and download and use these cases for teaching purposes as well. They're really lovely, lovely cases. And so, and highlight really 2 excellent papers that represent a lot of hard work. Overall, they present 12 important cases beautifully across both papers, but then there's also 14 additional cases presented through the Asia Learning Center, and really a masterful effort on the part of the Standards Committee and the authors of the papers. And so I'm grateful for their work and to the benefit of the field. And so I thank you for the opportunity to highlight these today and participate in the webinar.
Okay, so thank you very much, Ron. So we are going to open the discussion session, and I'm going to start with a question for the 3 panelists, and I'm hoping that that will generate more questions. Please remember to type your questions in the Q&A. So the first question for the group is, what clinical and practical needs motivated shortening the INSCI exam? And some of them were also addressed during the presentations, but Rudy, if you can provide some context on the historical challenges and clinical settings that led to the development of the expedited INSCI exam, that would be great.
I mean, there are definitely, and I think Stephen, you already pointed into that need. There are occasions actually then where you definitely need an abbreviated exam, because a full INSCI exams with 134 exam steps actually then simply is too time consuming to perform such a kind of a full exam. So this need actually is around there since decades. I think since 1992, when it has been implemented, actually, I think within the first 3 years, there have been already discussions about omitting some of the sensory exam parts then, because this is the really time-consuming part of the exam, particularly, and for those who do the exam regularly, the pinprick, so sharp-dull discrimination, and then a pinprick sensation exam, then that is really, really time-consuming. So there are many attempts then really then to reduce these kind of exam items then. And the e-INSCI version 1 that Stephen already mentioned, then that was published in 2020, was an attempt actually then mainly on a consensus base to determine the NLI and the AIS with the minimum number of exam steps. So really the absolutely minimum number. But over the time, actually, when we did perform this analysis, we found out that the accuracy, particularly, and also Stephen, you pointed it out in AISB patients, is not really very accurate. And we said, okay, we cannot recommend actually then its use anymore. But the problem actually was to fill actually then the gap. I mean, if you actually abandon one of these assessments, actually you have to fill somehow then actually then this gap. And it took us quite a long time. We then to come up then with this version 2 based on the algorithm that is presented in the manuscript, and to provide really clear guidelines still how to do a standardized, expedited or abbreviated exam. I think that's still important because it's not a whole new invention. It's still based on the examination procedures then of the full INSCI exam. And the main purpose and the main application for this is like you have the need for a quick screening, pre-screening in studies. So where you need to determine NLI and AIS then in order to decide is this person maybe then a candidate for inclusion of a trial, and then actually then identify those where you have to do a full INSCI then afterwards. Also, where you do a periodic monitoring actually then of the course of the NLI and the AIS. I mean, there is no actually the need then to do a full INSCI exam, and maybe then this quick exam, the e-INSCI exam, is actually then the way to go. And so all those applications where you don't actually have a lot of time, but you can actually accept maybe then a little bit of a reduced accuracy. These are the application points then for the exam.
Okay, thanks, Rudy. So, Stephen, can you talk a little bit more about the decision-making process for the algorithm? Because at the end, that is the important, that's determining the outcome. So why certain items were selected for the algorithm? And I know you mentioned a little bit in your presentation, but at least for our audience, it's very important to understand the decision-making process of that.
Sure. Yeah. So in the development, we also tried a maximum reduction of the exam. So some people who were doing version 1 by the instructions realized you could leave out some of the motor exam and on some patients if it wasn't needed for, say, determining between a C and a D, or motor sparing more than 3 levels below. You could selectively be leaving out parts. So we came up with a sort of excessively complicated way that some of those things could be omitted in reducing the exam. We went through these cases, and the reality was that about 10% were being classified incorrectly. These were patients with a more rostral motor level that we were missing based on these shortened approaches. So we reworked things. And if we did things in a different order, if we did pinprick first, what if we did motor first? What if we do full motor first? That was the most straightforward instructions in the end, and eliminated most of the cases where we were misidentifying the NLI and identifying something that was more caudal incorrectly. And the committee, went once again, well, do we think we want complicated instructions for potentially omitting those parts of the motor exam that aren't needed? Like, no, the motor exam is that's the important part in many clinical contexts. If you do the full motor exam, you can always calculate upper and lower limb motor scores. Let's just go with that, doing that part first. So that's how we arrived at do motor first, do the full motor exam. It's useful information. It gives us the other scores. It improves the accuracy where we were missing NLIs when we were starting with sensory, and leaving out part of the motor. The sequence, go ahead.
I'm wondering, Steve, because there is evidence that the motor score, the sensory scores, are a little bit more variable than the motor scores. I'm wondering if that also has an impact in the decision process.
I guess for the greatest reduction in the exam, we knew that there was going to be a large reduction in the sensory testing, and if any sensory is admitted, it's going to limit or eliminate the ability to be coming up with sensory scores. So we never looked at can we retain the sensory scores. We went with an approach of doing the minimal sensory testing needed to verify what the NLI is. So that's why the sort of non-intuitive sequence of we're testing one column starting at C2 and going caudal, and the other columns we're testing in a rostral direction, came up with. There are some odd cases in the EMSCI database. I'd say about half the cases that were difficult to classify, we looked at and said, we're not even sure these patients really have spinal cord injuries. Is there a second lesion? Is there another process going on? But that would be pretty disingenuous of us to just, okay, we'll just eliminate those cases that that are not working right. There's something wrong with them. I mean, it's the EMSCI database. We've got to assume these are in fact the exams that clinicians are coming up with. So some of the step-by-step was dealing with cases like that. The reality that there are a number of cases where there are no sensory deficits at all. And if we were starting sensory first, we would be doing the sequence. We would be testing C2 to S4-5 for light touch, and then all the way down for pinprick. And the instructions having to be actually quite complicated for how far you needed to go with the sensory testing in these patients with minimal sensory deficit. Whereas this approach of just doing the sensory testing needed to say, okay, the NLI, we've got all the information we need for NLI. We haven't defined the sensory level. On one side, sometimes on both sides. We could potentially, on some of these cases, only end up having enough information to accurately say about motor level on one side and not the motor level on the other side, which is a little hard to understand, and or either sensory level. So it's a different process coming away with doing this, not with our two sensory and motor levels, which really version 1 told you to identify those. That was the process of coming up with the NLI, was doing enough testing for sensory and motor levels. In this case, that's not it at all. I saw the first question that was in the chat about the sort of the sequence of the testing, or the why did we start at the or continue the sensory testing all at the sort of same dermatome level. It depends how much uh, level difference there is between the the sensory level and the motor level on one side, and then the sort of side to side asymmetry of the sensory levels, as far as which dermatome you will test next. The logic is always, when I move to the next column of testing, I'm verifying what was considered normal in the previous part. I'm using that as my starting point. So whatever dermatome I test next, if that's good, that's good. That's going to be an intact level. If that's abnormal and getting a 1 or a 0, I have to keep moving rostral. The example I showed is not necessarily the best example of that. If you look across all 4 cases, we have the different sort of combinations of, on an ipsilateral side, the sensory level, the motor level and the sensory level are essentially the same. Ones where there's sort of a one level discrepancy. So if you tested down to the presumed motor level, it's abnormal. You'd run into a 1 or a 0 at that level, and you move rostral with where you test in the next column. So I would say look across the 4 case examples. I may actually end up editing that case 1 to incorporate that change, so it can be showing in lectures just one single case that is the more common situation. But it's really across the 4 cases that you see that. You'd cross to the contralateral side, and the first dermatome you check ends up being abnormal there, and you need to proceed rostrally until you encounter a normal one. So the bottom line, how we develop this, the sequence needing to do it in this order, it was trial and error on cases that were challenging to classify, that were giving us the wrong answer with previous versions. Whether our instructions are super clear, it's hard to be really precise and really clear sometimes. That's been a challenge with the full standards as well. Being so precise makes something with lots of phrases and words and paragraphs, and that's just a challenge of it. And we may tweak the wording in what's posted on the Asia website for what is the testing protocol, but hoping that we can stay with the sequence that's specified in the algorithm that's in the manuscript. So we may just explain it with different words, and have to be explaining some special situations. What do you do if sensory testing is abnormal at C2? The first spot you check, well, you might be done at that point, because you know that it's going to be a C1 level on that side. Can't be any higher on the contralateral side. One dermatome of test and you're done. So some of the specifying may change in the instructions that are on the Asia website. And we someday may need to go to a different protocol. We could find a better sequence of the testing that gets us to the correct answer even more of the time. Or in less steps, or something more clear. But we're going with this one, and the algorithm is the validation that this is a highly accurate way with a greatly reduced exam.
Very nice. Thank you. So we have a number of questions, but before going to the questions from the audience, there's one more question for Ron. And Ron, based on your clinical experience, when is it most appropriate to use the full INSCI exam versus the abbreviated INSCI exam?
So a great and an important question that undoubtedly the field will wrestle with, and likely there will be some degree of clinical practice evolution in response to this. I really want to again congratulate Dr. Burns and the entire standards committee on the Herculean effort it's taken to get the expedited exam to the point it is, which is intuitive, does align really well with clinical practice, busy clinical practice, and as was identified, the research need for screening people potentially for level of injury and completeness for clinical trials. And so the expedited exam fills a tremendous need, but definitely cannot replace comprehensive exam, especially for the point of view of having detailed neurologic information about the overall degree of the sensory impairment. And that does have an important impact on clinical care. And so as a general of thumb, and Rüdiger and I have debated this a bit, I would agree that probably everyone should have at least one INSCI exam performed by an experienced examiner. That's not to say that it can't also be performed with people in training as well, because it's an important way of learning the details of the exam to do it on their own. But every patient should probably have one INSCI exam at some point. Now, in the case where someone is neurologically evolving in a way which is concerning, the details of the sensory exam can be helpful for picking up something like progressive syringomyelia. And so, in the expedited exam with minimal sensory findings, you may not pick up some important changes in sensory function. And that is one of the downsides to the expedited exam. But for day-to-day clinical practice, screening people, seeing people in follow-up who are progressing well, the details of the motor exam, confirming the neurologic level of injury, making sure there haven't been any concerning changes overall in terms of the completeness, the expedited exam is a tremendous addition to the field. And I'm, again, grateful for the work of the committee and the intuitiveness with which this exam is presented, because it makes good sense and flows with routine clinical practice. You do the motor exam, move on to key elements of the sensory exam, and it does eliminate some of the greatest challenges for the sensory exam because it's highly variable at times. And I think that's been the feedback from the field, is the variability of the sensory exam.
Very good. Thank you so much. So we have so many questions. So I'm going to start passing the questions from the audience. The first one is, how do you address the unique needs of pediatric patients during the INSCI exam? Any of you open for discussions?
Well, as a VA physician, I haven't examined a pediatric SCI individual in three decades. But it would be interesting to see if this can be performed with accuracy at a slightly lower age just than what's been shown for the full INSCI to be determining an accurate exam just from the large time savings there. Potentially it would, maybe a year younger or something would be my guess of where it's sort of attention span as opposed to sort of interpretation of the instructions and questions was the limiting factor.
Very
So,
good.
so,
Just again.
so
Go
Monica,
ahead, Rudy. Yes.
So Monica, I think an important information out there is I think there is a flyer actually then on Asia website describing the nature of the exam, the content of the exam, in particular for the pediatric population, meaning to inform parents actually then what is going on there with their children. And I think that this is definitely a case, or this definitely an application where I think I can omit 2% of NLI accuracy when I can omit actually then this large portion of the sensory exam. So here I definitely would say, I mean, the e-INSCI is definitely in the way to go. But because in practice, I guess, people will perform it anyway in an e-INSCI-like way. Let's phrase it like this, because simply, I mean, that's a challenge. I mean, then really in the pediatric population, so you cannot accept actually to do a 1 hour exam then because the children are not compliant enough.
So just a follow-up question, Rudy, or for the panelists. If we are already aware we're performing an INSCI on a patient with complete spinal cord injury,
Yeah.
the e-INSCI useful? Is there any advantage?
I mean, from the standpoint of the exam reduction, it still is an exam reduction. Not as you will need to check S4-5 for light touch and pinprick bilaterally, and you'll have to do an anorectal exam. There won't be a reduction in that part of the exam, but you're still going to be potentially cutting out a lot of sensory testing, rostral to the NLI, as well as between what determined the NLI and S4-5. So it still is potentially a large time savings in those patients. You're just not changing the sacral sparing part of the examination. You will have to run through all of that to determine someone's AISA, if I'm interpreting the question correctly.
Maybe a comment to that. I think what is really important, because I think there is another question then in relation to this. So what I would definitely not recommend actually then is really then to reduce the neurological characteristics of a patient to the NLI and the AIS, particularly in those patients with a complete, so meaning no sensory and motor functions in the lower sacral segments patients, because I personally believe that the ZPP, the motor scores, and maybe then also at least in the sensory CPP, is an important information actually there, because people are prone to develop neurogenic or neurological pain, neuropathic pain. And so I think that's, I did all of the classification variables actually that down there, I think are to some extent then really important. And not only, please don't reduce actually then 134 variables only to the AIS and think you can describe actually a patient to perfectionism. That's definitely it's a compression of information like crazy.
Yes, Rudy, a related question I think is coming from Ashraf. This means that we only perform the abbreviated version for only incompletes, but not for motor complete. So I think you addressed that a little bit, but it's important because this could create a confusion.
Oh, yes.
Yeah.
Sure. I mean, I think there is also a question then in the chat about the timing when a full e-INSCI exam actually should be done. Because I mean, I think that even different institutions handle that very differently. When you actually then write the diagnosis, I mean, of course, then the first INSCI exam results mainly are put then into the diagnosis, and this is the label that often patients have for their whole life. And I mean, that's really complicated. I personally, but I leave it also then up to the clinicians. I have no ideal, I would say, a time point then for an examination. We know that, of course, then if there is a dynamic in the neurological recovery, I at least want to have some information about this dynamic. So if you have a more complete lesion, I would say, okay, maybe we can do the exam then at the 4 weeks time point after the injury. But there might be cases actually where you actually want to track dynamics, where you need an earlier time point. So I'm really reluctant then to define the ideal time point when it has to be done. At least what we published then within the suggested uses then for the full INSCI is admission to inpatient rehabilitation, whenever that is. And I know that for different health systems this might differ to a substantial in a substantial amount of days, but nevertheless, I mean, that's the first exam we can get reliably. And to be very honest, the rehab persons, they are trained then to do the INSCI correctly, beside actually then more trauma-centered people where maybe then, a quick exam of does someone actually then move some of the muscles below the level of the lesion. I would say then the rehab guys are those who should at least then perform, Ron, you mentioned it, a baseline exam.
We have so many questions.
Yeah.
I think we're not going to be able to go to all the questions, but I'm trying to select. There is an interesting question from a colleague from Chile asking if you have observed any ceiling effects in these new versions of the INSCI exam and the changes that have been done overall.
Well, the classifications that we're getting are just the NLI, AIS, and motor scores, essentially the same as with the full exam. So it's, it would be just those limitations if you were treating a population with a, specific injury spectrum and they were motor incomplete with minimal deficits, then you would have potentially have a ceiling effect there. So it would just relate to the population and should be no different than the case for the classifications you're getting, those two classifications and the motor scores that you would get from the full INSCI. I mean, the main sort of difference thing would be the amount of testing, and what I had mentioned about these cases where you could get away with a complete exam. You've identified the NLI just testing light touch in one dermatome, C2, and it was abnormal. So you would have a range as far as the amount of testing potentially performed that's extreme, as opposed to the full exam where you always do all the testing.
I mean, to add on that, Stephen, then I mean, nowadays we have the problem that most of our patients, at least in our countries, are more non-traumatic patients, and there actually then very strange lesion patterns actually can occur. Like, you don't actually measure an impairment in any of the muscle functions. Actually, then in the motor scores you have a 5. Then, of course, it's always a question where to start, because we are starting with the E-INSCI at the presumed motor level, but there is no presumed motor level because they're all 5s. And so actually, I mean, if then the lemniscal tract actually then has an isolated damage, then you have to do then in the end a lot of sensory exams still. Then, I mean, depending on the level of the lesion. But I would not say that still there is a ceiling effect in this regard. So because I guess that the results will actually then be the same, but it is more or less than, well, I would say then the exam gets more or less than to the exam steps that are needed for a full INSCI exam. So in these highly asymmetric, and I'm not talking about left and right, but I'm really talking about motor and sensory actually as asymmetries. There it might be quite tricky, particularly in the non-traumatic population. And that's the reason why we are discussing within the committee then to have a validation of the E-INSCI in the non-traumatic population, which I think is also an important issue.
So if we think about research, go ahead, Ron.
Which I think I agree, the importance of
Yeah.
validating the accuracy for non-traumatics, because it is a different spectrum of what the typical pattern of impairments is. I suspect it's going to perform pretty well, have fairly high accuracy, just based on the number of very odd cases we saw going through, step-by-step classifying from the EMSCI database. So, but it may be a slightly higher NLI error rate, because they are patients with paraplegia and incomplete injuries more commonly.
So go ahead, Ron. Go ahead.
The one thing I just wanted to add to Dr. Rupp's comment about the timing of the INSCI exam is, from a clinical practice point of view, I would really encourage people to try to get the first exam somewhere within the first 4 weeks, probably ideally in the first 2 weeks, because there will be a degree of neurologic recovery occurring, and one wants to have that full exam data to think about prognosis, and having it in the first couple of weeks is probably a very solid clinical baseline. Now, sometimes that may or may not be possible depending on patient circumstance. And so if you end up, at 3 weeks out, but I think if admission to inpatient rehab is delayed for some reason, we are going to miss an opportunity to get important data. And so getting that first full exam within the first 2 weeks is probably the clinical ideal, because then we are setting a baseline and we can have something to compare to going forward.
Absolutely agree that a lot of the literature about this, favorable prognosis for improvement in AISB patients, that's, much of that is exams 3 to 7 days post injury. If someone becomes a B 3 months after injury, their prognosis for becoming motor incomplete is going to be a lot different. And then similarly, what's been published, which I know is controversial, as far as preservation of pinprick at S4-5 as a prognostic sign, that might also be a reason you would like to have a full exam early on that doesn't directly relate to the classifications, but prognostic sign of some individual exam items that you often would be admitting in a patient who has an incomplete injury if you follow the ENSCI.
Very good. So what about research? If we have a clinical trial or any research study, what is the opinion of the panel about the use of the full INSCI exam or the abbreviated INSCI exam? What should we do? What should we research?
The most important point is if sensory is going to be an important outcome or safety concern, you better be doing the full INSCI, because an e-INSCI may only require a very limited amount of testing. It would be insensitive to a great amount of recovery that was happening caudal to where you're doing your testing. If someone had a slight ascending sensory level, but we haven't actually identified the sensory level using the ENSCI, you would miss that. But I think there are potential applications in studies that are not primarily looking at neurologic outcomes or assessing that as a safety outcome, or for the step in the clinical trial where time is of the essence, something that had to be given very, very early and there wasn't time for a full exam.
Mm-hmm. So do you think that the expedited exam will be accepted by the spinal cord injury model systems and the MSKTC community?
Accepted for what time point, I guess, and for
Yes.
what purpose or not?
That is the general question in the chat, but I guess there's no more details. But what is your view about the role of this expedited in terms of the model systems, spinal cord injury model systems?
Well, I certainly wouldn't want to speak on behalf of the Model Systems Program or anything like that, but certainly the pressure of collecting consistent data and the impact of the full exam as it relates to just the ability to get any information are longstanding challenges. And so integrating an abbreviated exam that's standardized to get more data seems like it could be potentially beneficial for sure. Defining when you might use this instead of the full exam, of course, will take a data-driven decision-making approach. But I would certainly hope that anything that can provide efficiency, but without losing critical data, would be considered.
And Ron, to add on that, I know I'm from the other side of the ocean, and should not maybe then talk about this, but I mean the abbreviated exam or the expedited exam, I mean it is better than nothing. So if you miss actually then an exam, then do an abbreviated exam, because you still have the motor exams, particularly at follow-up time points. I'm not talking about really then the first exam when people are admitted then to the hospital, but for follow-up exams, because still we are able then to track the motor part of the exam. And Stephen, you already pointed it out. 34% on average actually then of the exam items then are only needed then for the expedited exam. And I mean this means typically actually that you save a lot of time. Actually then you save 60% of your time. So if it helps to get some information, then do it. Better than nothing. I mean, better than simply saying, "Oh, I was too overwhelmed. I have no time." No, it's that's the reason. I mean, at least there should be then the opportunity to. That's also something I think Stephen, you already pointed that out. Then use the comments box and simply identify that this data that you entered is based on an e-INSCI exam. That's the only thing that's really important. So not that people think you have missed parts of the exam because you had no time or you have to stop it somewhere, but simply actually then to make clear, no, this was a structured exam following actually then the procedure and the steps, the examination steps of this standardized e-INSCI exam, and outline it in the comments box.
So then there is an interesting question in the chat. So if I use the full INSCI exam at the beginning and admission, can I use the expedited INSCI exam at discharge? Is it comparable?
I mean,
Or do we compare
likely,
the full
yeah.
INSCI exam with the full INSCI exam and the expedited with the expedited?
Likely yes, because you're going to get a highly accurate AIS, so you will know if that is changed. Looks like AIS is extremely accurate. You're going to have the full motor exam, so you can see how much motor recovery occurred from early on or not. Yeah, ideally you'd have an updated full sensory exam to know if somebody's having a change in the future, but it's not a compelling case that that's going to be needed. So, you know, in my own institution, which is not a model system site, my staff are doing e-INSCI at rehab discharge. And I'm not sure we're really missing anything important.
Okay, so what are the professionals who should be using the INSCI exam? Medical doctors, therapists, what is the staff that should be doing the INSCI exam, in your opinion?
So first of all, I think it should be trained persons, so that actually know what to do. So we had, so for the motor exam, it helps if people are actually then knowing then how to perform a motor exam in regular clinical practice. So physiotherapists, occupational therapists, and physicians. I mean, these are the people to go. But I know at least one engineer actually that also knows how to perform a manual muscle test, which is me. And so, but nevertheless, there needs to be, I think what is really important, and we see this also during trainings, particularly in the discussions with physiotherapists, there are always actually in discussions, you cannot test this muscle for this muscle grade actually in this position. That's not the matter here. The matter here is we do it, we need to know actually then in which position, in which specific muscle position actually then a specific grade actually is tested in order to get reliable and particularly comparable results then among examiners. So I don't think that the focus should be too much on the profession actually then he's doing the exam, but really then on the training skills, actually on the training and on the skills, how people, so that people can actually perform it consistently.
So how frequently should we do the exam? I'm asking this if I conduct a clinical trial, for example, and the training period is 5 days or 10 days. Usually we don't tend to think about the changes in the INSCI exam. But if I conduct a clinical trial that is 2 months or 3 months, we usually include the INSCI exam. So what is your recommendation? How often should we use the INSCI, the full INSCI exam or the expedited INSCI exam?
I'm going to have to run, unfortunately. I have a clinical team waiting on me. So I'm going to answer this and then have to step off. And so I would say that you know, the full INSCI exam should at least be annually for the first year or two. But for a clinical trial where especially sensory score data might be very important, probably something in the range of a monthly exam would be reasonable, especially for an early phase 1 or 2 trial. For a phase 3 trial where you have a good bit of previous data, the expedited INSCI might be perfectly appropriate if it's primarily focused on motor outcomes and locomotor recovery, et cetera, but versus the details of the sensory exam. So again, I want to thank everyone. I apologize for having to sign off, but I know my team is waiting. So
Ron, thank you so much.
Absolutely. I think I want to thank also all the panelists for the discussion, for the presentations. I want to thank the Asia organization for supporting the webinar. I want to thank the editorial staff at TSCIR for putting together this important webinar. And I want to thank all of you and the audience for your questions. We will send back, you will receive an answer to your question by email if we were not able to address it during the webinar. And we want to invite you also to our next webinar that will take place on January 13, 2026. and we invite you to participate and be part of TSCIR and continue to support the Asia organization and our journal. So thank you very much, Rudy. Thank you very much, Stephen, for joining us, and thank you for everyone for joining us today.
And thank you, Monica, for organizing all of this and your interest and the so that you led us through these discussions. Thank you so much.
Thank you.